Hello everyone, I'm Dr. Tharani, anesthetist from Hospital Tula Intan, and I'm going to be speaking to you today about critical care of dengue patients in ICU. To begin, I have outlined the important aspects of this presentation, which will be started off with an introduction, followed by indications for ICU referral, role of intensive care unit, and also the guide on safety and risk of invasive procedures. As we are all aware of the 2009 WHO dengue classification and level of severity, it classifies dengue into dengue with or without warning signs and severe dengue, which may present with severe plasma leakage, severe hemorrhage, and severe organ impairment. Please do refer to the fine prints on the diagram. Moving on to clinical cause of dengue, it is divided into three phases: the febrile, critical, and recovery or reabsorption phase. During the febrile phase, patients usually present with fever and are also accompanied with symptoms such as generalized body ache, facial flushing, rash, vomiting, and headache. The earliest laboratory changes seen are usually a progressive reduction in total white count, followed by platelet reduction. As dengue is a systemic and dynamic disease with clinical, hematological, and serological manifestations, which changes from time to time, so these changes may accelerate drastically during the critical phase, especially in those with plasma leakage, which subsequently may lead to organ dysfunction. Here I would also like to highlight that during this period especially, patients usually require critical care admission and continuous monitoring in the ICU, as they may go into compensated or decompensated shock. During the recovery phase, patients' general well-being improves with stabilization of hemodynamic status, and improvement in the laboratory parameters are also seen. Caution should be applied in patients with pre-existing comorbidities such as congestive heart failure and renal disease, whereby close monitoring and management of fluid therapy is clinically indicated, and it should be tailored according to case-to-case basis. This is to ensure that patients do not tip over into a decompensated state. Again, I would like to highlight that clinical deterioration often occurs during the critical phase with plasma leakage or organ dysfunction, and this is evidenced by raised hematocrit, hemodynamic instability, fluid accumulation in extravascular space, or hypoproteinemia. Patients with clinical warning signs of dengue infection have a high possibility of rapid progression to severe dengue. Moving on to indications of ICU referral. This is based on the dengue CPG guidelines of 2015. It is divided systematically into different organ systems, and based on the respiratory system, these are the indications. Acute respiratory distress with the following clinical signs: a rate of 13 breaths per minute, dyspnea, use of accessory muscles, agitation or confusion, high levels of supplemental oxygen, requiring an oxygen concentration of more than 50% to maintain a saturation of more than 90%. Risk of respiratory compromise with large volume resuscitation. For an example, patients with congestive heart failure and also chronic kidney disease. Massive hemoptysis. And in patients with a potential need for non-invasive or invasive ventilation. Cardiovascular. Hemodynamic instability due to hypovolemia, hemorrhage, myocarditis, or other causes. Complex cardiac dysrhythmias requiring close monitoring or prompt intervention. Patients with underlying cardiac disease with risk of cardiorespiratory compromise, for an example, patients with an unstable ischemic heart disease or patients with fixed cardiac output states. Neurological manifestations such as seizures and CNS depression. Gastrointestinal. Patients with acute gastrointestinal bleeding coupled with hypotension or continuous ongoing bleeding. Severe acute hepatitis as well. Hematological. Patients with severe coagulopathy and significant bleeding. Renal. acute kidney injury, or acute rhabdomyolysis with renal insufficiency. The ICU care and management follows the general principles of a critically ill patient. Close and continuous monitoring of vital signs and clinical assessment of patients should be intensified and may be aided with non-invasive or invasive monitoring techniques in the ICU. Strict monitoring of ongoing fluid losses and hourly fluid input and output charting is mandatory. Implementation of organ support should be carried out early, such as ventilatory, cardiac, and renal support as required. As we know, monitoring is crucial in all aspects. Based on the clinical parameters, patients' general well-being and ongoing symptoms are kept in check at all times. The patient's hemodynamic status, which comprises of color, capillary refill time, temperature, pulse volume, pulse rate, blood pressure, and pulse pressure. Patient's respiratory status comprises of the respiratory rate and saturation. Neurological status such as presence of an altered mental state. Urine output monitoring to detect oliguria or anuria. Serial laboratory parameters are done depending on the clinical status of the patient, which comprises of a full blood count, whereby we may see hemoconcentration, a reduced total white count, and also a reduced platelet count. Renal profile, presence of electrolyte imbalances, such as hyponatremia and hypokalemia, and also presence of AKI. Liver function test, deranged liver enzymes, with usually a count of AST more than the ALT, a coagulation profile to detect coagulopathy. Arterial blood gas analysis and lactate is frequently done in patients with severe dengue or in patients with shock, mainly for detection of pulmonary gas exchange and also the worsening metabolic acidosis. Other electrolytes such as calcium, magnesium, and phosphate should be done as well and abnormalities corrected. In the ICU setting, we are able to provide the patients with additional serial imaging techniques such as echocardiography, non-invasive cardiac output monitoring, and ultrasonography. However, in patients with a central venous catheter in situ, these parameters may be used as a guide. Parameters such as CVP trend, central venous oxygenation monitoring, and also CO2 gap. They are used as a guide to determine adequacy of the perfusion or microcirculation and also the fluid status of the patient. Central venous oxygen monitoring of less than 70 shows inadequate oxygen delivery to the tissues. This can be improved by increasing the cardiac output, which are the heart rate and stroke volume, and or to optimize the hemoglobin level to increase the oxygen carrying capacity. The CO2 gap, which is also known as the venous to arterial CO2 difference, indicates adequacy of the microvascular blood flow and perfusion. Normal values are less than 6. So if venous to arterial CO2 difference is more than 6, it is likely due to sepsis. If it's less than 6 but with presence of hypolactatemia, the contribution could be due to liver failure or other causes should be ruled out as well. As mentioned earlier, disease progression and clinical deterioration may occur rapidly during the critical phase. The issues that may ensue during the critical phase are an acute increase in vascular permeability, thus leading to plasma leakage into the extravascular compartment. This results in hemoconcentration and hypovolemia. This may then lead to compensatory shock. Body compensates by peripheral vasoconstriction to maintain the mean arterial pressure. There could be narrowing of pulse pressure and a raised diastolic pressure. presence of skin coolness, pallor, delayed capillary refill time, tachypnea of a rate more than 20, persistent GI symptoms, and also an altered mental state. Pulse pressure of less than 20 and systolic pressure of less than 90 are late signs of shock. These clinical and hemodynamic parameters should be monitored closely and acted on promptly, as inadequate perfusion may progress into refractory shock. This can then lead to organ dysfunction and multi-organ failure. Here I would like to highlight that the frequency of monitoring actually depends on the clinical status of the patient. The frequency usually progressively increases during the critical and recovery phase, necessitating intensive care. So in patients with deterioration, or in patients with severe dengue, or patients in presence of shock, the monitoring is done as frequent as every 15 to 30 minutes, still stable, and then reduced to 1 to 2 hourly. This applies similarly to the serial laboratory investigations. Now, methods of monitoring for volume status and fluid responsiveness can be divided into non-invasive and invasive methods of monitoring. So there are a few non-invasive methods that can be used, which are the passive leg raising test, transthoracic echocardiography, ultrasound, and ASCOM. This is also known as the ultrasonic cardiac output monitors. Invasive monitoring that can be used is an arterial line, which provides us bit-to-bit blood pressure monitoring, serial blood gases and investigation, pulse pressure variation to determine fluid responsiveness. The passive leg raising test is actually a bedside maneuver that's easy to perform. Patient is placed in a semi-recumbent position with the head of the bed at 30 to 45 degree position. Rapidly move the bed to simultaneously elevate the lower limbs to a 30 to 45 degrees above the horizontal level while lowering the head of the bed to supine position. This may transfer 250 to 350 ml of blood from legs and the splanchnic reservoir to intrathoracic compartment, rapidly increasing preload and thereby testing the preload dependency of the heart. Peak change is usually seen at 60 to 90 seconds. Stroke volume change of more than 10% is fluid responsive. So in this diagram, we can see actually how the maneuver is done. So firstly, check that the trunk is at 45 degrees, and then use the bed adjustment and avoid touching the patient, as this may cause alteration in the hemodynamics. So lower the bed simultaneously as the edge of the bed is propped up to a 30 to 45 degrees position, and at the same time a real-time measurement of cardiac output monitoring can be used. It can be used with an echocardiography or pulse contour analysis. Subsequently, reassess the cardiac output in the semi-recumbent position, and this should return to baseline. Advantages of this test: it is reversible, it is non-invasive, it can be used in patients with arrhythmias, and it can be repeated as many times as required for reassessment. The disadvantages are that it is unreliable in severely hypovolemic patients, need to stop other interventions during the test. Positional changes may be contraindicated in some patients, for example, patients with a raised intracranial pressure, and it is also not useful in patients with a raised intra-abdominal pressure. Transthoracic echocardiography provides a wealth of qualitative and quantitative information. For example, fluid responsiveness. The diameter of the left ventricle outflow tract is measured in the parasternal long axis view, and the velocity time index is measured using the 5-chamber apical view to get the stroke volume variation. This stroke volume variation is a good indicator for fluid responsiveness. So what is stroke volume variation? It is a change in the amount of blood ejected from the left ventricle into the aorta with each heartbeat. A stroke volume variation of more than 13% is indicative of fluid responsiveness. The left ventricular end diastolic volume is a surrogate, or it approximates the preload of the patient. Other than that, cardiac function, motion wall abnormalities, and pericardial effusion can all be determined and detected as well. Unfortunately, there is limited data of the use of echocardiography in patients with dengue. There are evidence of significantly reduced ejection fraction during critical stage in severe dengue. Other than that, information regarding systolic and diastolic dysfunction, regional wall motion abnormalities of septum and right ventricular wall may be obtained, indicated in refractory shock despite adequate fluid resuscitation, and also in suspected cardiac dysfunction. So the diagram on the left is an echo that is done in the parasternal long axis view, and it shows that there is kissing of the ventricular walls. This indicates that there is presence of hypovolemia. Whereas the diagram on the right shows that there is a hyperdynamic left ventricle with an end diastolic area of less than 10 centimeters squared. This is taken in the parasternal axis view, short axis view, and this is also strongly indicative of hypovolemia. Ultrasonography may be advantageous in looking for evidence of third space fluid loss, for example, presence of pleural effusion, pericardial effusion, ascites, or even gallbladder wall edema. It may also be used to measure adequacy of IVC as an indirect indicator of intravascular fluid compartment status and response to intravenous fluids. The collapsibility index is then used to measure the fluid responsiveness, and it's usually done in a spontaneously breathing patient. This imaging should be performed by trained personnel and not to be interpreted in isolation. So the diagram on the left shows that there's presence of moderate pleural effusion, and the diagram on the right shows that we can actually measure the pleural effusion in centimeters from the chest wall to the pulmonary parenchyma. This is actually beneficial because it can be done in a serial manner, and we can actually monitor the increase or the decrease in the pleural effusion. The picture above shows that there is a moderate pericardial effusion in the parasternal long axis view, and the picture below shows that there is presence of ascites. Okay, this is a diagram of inferior vena cava measurement in the M mode. The maximal and minimal diameter are measured, and the collapsibility index is then obtained to determine the fluid responsiveness. So if it is 40%, more than 40% collapsible, then this patient will be fluid responsive. Serial monitoring of the fluid status and responsiveness is helpful in determining the current clinical state, and prompt management and treatment may be instituted as well. Okay, so moving on to organ support, respiratory support. The main objectives would be to support the pulmonary gas exchange based on alveolar ventilation and arterial oxygenation. It may also help to reduce the metabolic cost of breathing by unloading ventilatory muscles. And the indications are as the following: patients in persistent shock, patients with acute respiratory failure secondary to massive pleural effusion with or without ascites, and patients with fluid overload. also in patients with severe metabolic acidosis and those who require airway protection. Patients who are alert, cooperative, and hemodynamically stable, but with presence of a mild metabolic acidosis, they may benefit from non-invasive ventilation. So, for example, in this patient, this is a patient in recovery phase and he developed pulmonary edema with pleural effusion. So non-invasive ventilation, CPAP, was applied, and as you can see in the subsequent X-ray, there is gradual improvement in the and reduction in the pulmonary edema and pleural effusion. Invasive respiratory support. Hypoxemia is a guide to actually warn us of the probability of fluid overload, pleural effusion, and interstitial edema. Caution must be taken to avoid trauma during intubation because this may lead to bleeding. Intubation strategies in a patient, like for example in this patient who has dengue, they are usually at a maximal catecholamine drive. So in these patients, we may consider IV ketamine as an induction agent and also do consider using half the dose of induction, especially in patients presenting with shock. Initiation of a positive pressure ventilation will further reduce the cardiac output by reducing the venous return. Patients with presence of pleural effusion and ascites will have hemodynamic compromise, especially when higher airway pressure is applied to achieve adequate ventilation and oxygenation. Patients with metabolic acidosis, respiratory support can be considered despite preservation of relatively normal arterial blood pH. Winter's formula is actually a formula that is used to calculate the expected PaCO2 in patients with metabolic acidosis. So when a patient with metabolic acidosis is on invasive mechanical ventilation, we should set the ventilator settings so that the PaCO2 remains low at the expected PaCO2 level. Failure to do so may cause further deterioration as the acidosis markedly worsens, resulting in depression of the myocardial contractility, presence of hypotension, and may also lead to arrhythmias. If the actual PaCO2 is higher than the expected, this actually is to compensate for the acidosis. So consider intubation and mechanical ventilation in these patients. If the actual PaCO2 is lower than expected, this indicates that there is mixed respiratory alkalosis and metabolic acidosis, and these are usually seen in patients with liver failure, dengue encephalitis, sepsis, and in patients with pleural effusion and moderate ascites. Hemodynamic support. Fluid resuscitation, as we all know, is crucial and is the mainstay of treatment of shock, and it should be initiated early. So it should not be delayed while waiting for ICU or HDU admission. Volume and rate of fluid replacement should be titrated to clinical response to maintain an effective circulation while avoiding over-replacement. No clear advantage of colloids over crystalloids are documented except in patients with intractable shock in initial resuscitation. If a patient is in persistent shock, other causes need to be considered as well. So other causes of shock, for example, septic shock, hypovolemic shock due to bleeding and leaking at the same time, cardiogenic shock due to cardiac dysfunction, liver failure with severe metabolic acidosis from lactate accumulation, and also patients with cytokine storm. Hemodynamic support. Cardiac dysfunction is not uncommon in dengue infections with shock, which manifests as arrhythmias and hemodynamic instability due to myocarditis and myocardial dysfunction. Cardiac complications should be suspected in fluid refractory shock or in patients with hemodynamic compromise which is disproportionate to capillary leakage. These patients, they require close monitoring and prompt intervention. It is also recommended to do an ECG, cardiac biomarkers, and echocardiography in these patients. Adequate fluid resuscitation is a prerequisite before myocardial dysfunction can be diagnosed. Management-wise, cautious volume resuscitation is required in those with myocardial dysfunction, just sufficient to maintain an adequate tissue perfusion. The role of inotropic and vasopressor agents in dengue shock has not been investigated in clinical trials thoroughly. Vasopressors may be able to maintain the blood pressure, but they do not improve tissue perfusion if the intravascular volume has not been restored. The use of inotropic and vasopressor agents are limited. You can refer to the algorithm C in the CPG guidelines. But they can be used as a temporary measure to prevent life-threatening reduction in blood pressure, while aggressive fluid resusc is carried out or during induction for intubation. In patients with cardiogenic shock, it is appropriate to use inotropic agents such as dobutamine or adrenaline with or without a vasopressor. In concomitant septic shock, noradrenaline is the preferred inotrope compared to other vasopressors as the first-line therapy. In patients with liver failure, the mainstay of treatment is still supportive. They are managed with appropriate fluid management, monitoring of hemodynamic and metabolic parameters. Use of IV NAC in acute liver failure has level 3 evidence. Artificial liver support systems have not conclusively shown to be beneficial for dengue-related acute liver failure. Renal and acid base. Compensated metabolic acidosis is an early sign of shock due to leakage or bleeding, and prompt intervention should be done. Lactic acidosis due to tissue hypoxia and hypoperfusion is the most common cause of metabolic acidosis in dengue shock. So we should aim for a lactate level of less than 2 millimoles per liter for adequate tissue perfusion. Suspect other causes in persistent acidosis despite shock correction and fluid replacement therapy, such as severe bleeding, cardiac dysfunction, liver failure, patients in sepsis, or patients with AKI, patients on various other drugs, or in those with hypochloremic acidosis. Sodium bicarbonate for metabolic acidosis caused by tissue hypoxia is not recommended for a pH of equivalent of more than 7.1. This is because bicarbonate therapy may cause sodium and fluid overload, increase in lactate and PCO2, and reduced in serum ionized calcium. A delay in lactate clearance or persistent increase in lactate is associated with poor outcomes. They may also contribute to cardiac depression, arrhythmias, vasodilatation, increased respiratory muscle workload, reduced oxygen delivery, reduced ATP production, and may also lead to multi-organ failure. A useful parameter to guide therapy is lactate clearance. Lactate clearance is calculated as shown, and a 20% clearance in 2 hours improves survival. So renal replacement therapy should be provided early in the course of AKI to prevent worsening acidosis and fluid overload. Continuous veno-venous hemodialysis is preferred over the intermittent HD due to the associated hemodynamic instability. They may not help to efficiently clear the lactate levels, but they actually help to keep the acidosis at bay. Okay, so moving on to guide on safety and risk of invasive procedures. For example, for CVC, arterial catheter, gastric tube, pleural tap, and chest drain placement. So for CVC and IV access, rapid and large volume of fluids can be infused via a large bore peripheral venous catheter in fluid resuscitation. A well-sited proximal peripheral venous catheter is sufficient for short duration of vasopressor. For example, if it's only required for 1 to 2 hours. CVCs are long and they have multi-lumens with small individual lumen. The need for CVC arises when there's inadequate peripheral venous access and requirement of infusion of vasopressors for a prolonged period of time. Avoid the subclavian approach as the subclavian artery and vein is not accessible to direct compression. Use of a real-time ultrasound guidance is recommended for CVC insertion if it is available and there is expertise. Routine prophylactic transfusion of platelets and fresh frozen plasma in severe thrombocytopenia prior to the insertion of CVC should not be done as there is no clear evidence to support this practice. If platelet is to be transfused, a CVC should be done within 4 hours following transfusion for a maximum effect. The most recent recommendation by the American Association of Blood Banks suggested that transfusion as low as 20,000 prior to CVC insertion is recommended. Invasive procedures. Arterial catheter placement. This is useful for continuous arterial pressure monitoring and serial blood sampling. The rate of bleeding complication is actually low and the lowest risk is in the radial artery. Nasogastric tube should be avoided in patients with bleeding disorder, and you may consider an orogastric route placement. Intercostal drainage or pleural effusion should be avoided as much as possible as it can lead to hemorrhage and sudden circulatory collapse. Okay, so the take-home message for today would be that dengue infection is a dynamic disease and the key to favorable outcome is frequent monitoring and changing the treatment strategies. Fluids have to be given at just the right time, in just the right volume, of just the right type, and for just the right duration. Recognition of shock in its early stage, which is compensated shock, and prompt fluid resuscitation will give a good clinical outcome. Okay, thank you for listening and have a nice day.